My name is Dr. Ellen Taylor. I am the co-director of simulation training here at Princess Margaret Hospital for Children. We have created this video with a grant from the WA Clinical Training Network, and we're grateful to them for their assistance. Paediatric resuscitations are daunting for many staff and they don't happen very often. Therefore, many staff will not have had the opportunity to take part in a paediatric resuscitation during their career. They may not even have seen one. We wanted to create a video to highlight what the first few minutes of a ward-based resuscitation might look like and to highlight some of the non-technical skills that are involved. After watching this video, we hope that you will have a good understanding of what non-technical skills you will need in a paediatric resuscitation, whether that's simulated or real. This video may form part of a workshop or further discussion, or stand alone as part of your own self-directed learning. We hope it will be helpful.
I need some help. There's something wrong with my baby.
Okay. Let's have a look. Charlie! Charlie! Can't hear him breathing. I need some help in here, please.
Calling for help early is a vital part of any crisis. This should be done by shouting and pressing the nearest emergency buzzer. Generally speaking, you should do this when you start to feel uncomfortable in a situation and when there are too many tasks to perform on your own. Remember, it is better that help arrives early and that the crisis isn't as serious as first thought than waiting until a situation is out of your control and wasting valuable time.
Okay. Come on, baby. This is Charlie. He's 3 months old. He's coming with severe dehydration. I can't feel a pulse and he's not breathing, so...
Okay, Charlotte, can you start airway, please? Deb, can you start compressions?
I need to ring my husband.
I'll just connect this up. You can help with that.
I'll go and call the code blue.
Early role allocation in a crisis helps improve the speed of response, team performance, and gives structure to an already difficult and stressful situation. Role allocation can be self-assigned or assigned by the leader. Remember, it's important to try and get people into the most appropriate roles for their skill set. Having the wrong person in the wrong role may result in error or failure to deliver the best care.
Okay, I'll do two-handed technique if you can bag.
Code blue, PMH, Ward 2A, room 5.
14, 15.
That's good.
2,
Good chest expansion.
6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 13, 14, 15.
The most important part of any resuscitation is the immediate commencement of good quality basic life support. This should be maintained the whole way through the resuscitation with minimal interruptions. Good quality BLS will preserve blood supply to the body's vital organs and is absolutely critical to a good outcome. Remember, most people can only maintain good quality chest compressions for a 2-minute period, so staff should be rotated into and out of this role regularly.
1, 2, 3, 4, 5, 6, 7, 8, 10, 11, 12, 13, 14, 15. 1, 2, 3.
I've called a code blue.
5, 6,
Hi, I'm
7,
Tom, I'm the
8,
GE
9,
medical officer.
10,
What seems to be
11,
happening?
12, 13,
This
14,
is Charlie.
15.
He's 3 months old, came in with dehydration. Found unresponsive with no pulse, so we started CPR.
My name is Lisa. I'm the nursing clinical educator in the emergency department. ISABAR is an effective tool for use in handover. Even under stressful or time-critical circumstances, it can be used to help structure important information that needs to be handed over. Usually in a critical situation or resuscitation, there are essential pieces of information that the team will need to direct their management. The importance of a succinct but thorough handover cannot be underestimated. Remember, most members of a resuscitation team will know nothing about the patient when they arrive.
11, 12,
Okay, well I'm
13,
going to lead
14,
this until the
15.
code blue team arrives. Let's start with airway, breathing and circulation. Charlotte, what's happening with the airway and the breathing?
We've got a good seal with two-handed technique and we've got good chest expansion.
Okay, Deb, I'm going to briefly ask you to pause CPR so you can check a pulse for us. Can you do that now?
There's no pulse.
Okay, continue CPR, please, Deb. Okay, Margie's got the pads on. All right, now we've got the defibrillator on now. So again, we're going to do a brief pause in a second while we charge the defibrillator up to 4 joules per kilo, which is 20 joules.
Charging up to 20.
Okay, so away with the oxygen first. Continue CPR. Away with the oxygen, please. Continue CPR. Okay, we're fully charged now. Stop there, please, Deb. Okay, we've got asystole, so dump the charge and back on the chest doing CPR, please, Deb. Okay, back on the airway as well, guys. Thanks very much. Okay, we're in asystole. We're on the non-shockable side of the algorithm, so we're going to do adrenaline every 4 minutes.
All right, I'm on to adrenaline top.
Yep, pulse checks every 2 minutes. I'm going to get the algorithm off the resus cart.
Strong leadership is a very important part of creating a cohesive team. Explicit announcing of leadership helps prevent confusion as to who is leading. The leader should ideally stand at the end of the bed and not take part in any practical tasks, as these could be distracting to them. The scribe should stand alongside the leader to document timings, give prompts and record orders and actions that have taken place. Leaders aim to give direction to the team in terms of specific role allocations, tasks to be carried out, as well as giving the team focus and direction as to where the situation is heading. Leaders should not be dictatorial, but inclusive and welcome suggestions from members of the team. The leader does not necessarily need to be the most experienced person in the room, and co-leadership can be formed in appropriate circumstances.
11, 12, 13, 14,
Okay, Margie, we're going to need 10 mics per kilo of adrenaline. Charlie's 5 kilos, so we're going to need 50 mics of adrenaline. That's 0.5 mils of 1 in 10,000.
All right, 0.5 mils of 1 in 10,000 adrenaline. I'm drawing that up now.
Okay.
Effective communication is critical to ensure that the team works well together to achieve the best possible outcome. Communication errors are among the most common errors in resuscitations. Closed-loop communication is an effective method of communication and has been shown to reduce error rates by removing ambiguity from instructions, allowing questions if the instruction was not heard clearly, and allowing others in close proximity to be aware of the proposed course of action. Once a team leader has either requested information or asked for a procedure to be performed by a named person, that person should then acknowledge this request verbally and then confirm it when it is done. This allows for clarification of requests if needed and avoids errors of omission. Closed-loop communication allows the sender to know that their requests have been heard and understood. The use of names avoids the problem of such requests being made into an empty space. When a team leader asks out loud for a procedure to be done, unless they specify who they want to perform the procedure, then there will be a risk it will not be done at all. If possible, the team leader should use eye contact when making requests, allowing for non-verbal as well as verbal clarification. If the team names are not known, it's perfectly acceptable to address staff members by their role allocations, such as airway nurse or circulation doctor. This is another reason why role allocation is so important.
2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
Okay, adrenaline's going in.
2, 3, 4, 5, 6.
I think that the resuscitation dose of adrenaline is one of the few drug dosages that doctors and nurses working in a paediatric setting should know off by heart. It's worth understanding that 10 mics per kilo is equal to 0.1 mils of 1 in 10,000 adrenaline.
Okay, that's 10:04. The next dose is due at 10:08. Can you continue with CPR, please?
Yeah.
5 mil flush of saline.
Let's continue with the CPR. Deb, are you getting tired there?
No, I'm okay, thanks.
Okay, Grant, thanks. Okay, we've got the APLS algorithm out now for the non-shockable rhythm as well.
When you are a team leader, it can be very difficult to act effectively if you are trying to remember the relevant algorithm in your head. That's why we recommend getting the algorithm out and placing it on the table in front of you and the scribe. This means you can free up space to think about all the other details. The algorithms can be found on the resus trolleys, and specific algorithms can also be found on the APLS website. If you will regularly be acting in a team leader position, I recommend that you keep a copy of these on your phone or somewhere that you can find them easily when you are in an emergency situation.
Lovely, thanks.
Hi, I'm Emma. I'm one of the other RMOs. Do you need some extra?
Yes, please, Emma. Emma, could you take over CPR from Deb, please? Okay. Deb, can you come and come here and start scribing for us and look at the cognitive aid of the non-shockable side of the algorithm?
Okay. So what time did we start?
We started at 10:04. We'll get a first dose of adrenaline at 10:04. Yeah. We need to do the next dose at 10:08. We'll do a pulse check at 10:06. We're still in the first cycle of CPR.
Right, thank you. The role of the scribe is to maintain an accurate and legally binding account of a critical event. As part of this, the scribe will be tasked with capturing the time of onset of an event, details of the event, observations at 2-minute intervals, all interventions, procedures, medications and fluids given, capturing all treating staff and family members present, and communication with all treating teams and ensuring the family are supported. An important feature of this role is co-location with the leader of the resuscitation to ensure information is accurately captured in what can be a noisy space.
Hello, I'm Mary, I'm the anaesthetist. Would you like me to take over the airway?
That would be great. Thank you, Mary.
There you go.
Yeah.
Charlotte, could you go off and find Mum and explain to her what's happening?
Sure.
Alana, can you come and help Margie with drugs and medications and fluids, please?
It's coming up for 2 minutes where you need to check the pulse.
Okay, let's briefly pause CPR and check a pulse, please, Emma.
There's no pulse.
Okay, continue CPR, and there's still asystole on the monitor.
It's just such a terrible shock. Is he going to be all right?
The team is with him now and they're doing everything they can.
Can I please ask who the leader is?
Yeah, I'm Tom, I'm the junior medical officer, and I'll be leading until the rest of the Code Blue team arrives.
Okay.
The emphasis in much resuscitation training is on leadership. However, I think good followership is essential as well. In many critical events, somebody in the room could have changed outcomes had they spoken up. Good followers are accountable for their actions. The leader's role is to create the environment so that this can happen, but good followers can facilitate this too. And that could involve asking explicitly, who is leading this resuscitation? It could involve speaking up with concerns by using a graded assertiveness technique. It means being engaged and responsible together with the whole team.
Do we want to consider our 4Hs and 4Ts?
Yeah, that's a good point. Okay, let's do an overview. I think we've got, let's just so everyone can hear, we've got a 5-kilo, 3-month-old child in asystolic cardiac arrest. We've got a history of severe diarrhea and vomiting over the last 3 to 5 days. We are in the non-shockable side of the algorithm. We've given 1 dose of adrenaline. We're now going to start consuming 4Hs and 4Ts.
This is my patient, and I think that's consistent with his presentation. He came in very dehydrated yesterday.
Here, you have just heard the team leader use explicit communication, repeating the assessment and stating the working diagnosis and treatment aims out loud. This is a useful technique which allows questions to be asked by the team. It avoids team members working on counterproductive tangents and therefore avoids errors. It allows the entire team to create a shared mental model of the patient's situation. This means that all team members can understand both the clinical and logistical implications of the case. It ensures that team members are familiar with one another's roles and responsibilities. They can anticipate the needs of other team members. This collaborative approach helps break down boundaries between individuals with varying levels of expertise, and it helps reduce the perception of a power differential between professionals.
I think we're going to need a fluid bolus of 20 mils per kilo, Margie, 100 mils of normal saline.
Yes,
and we'll need a venous blood gas taken off so we can check the electrolytes. Does anyone have anything else they want to add at this stage?
Oh, hi, I'm Simon, I'm the ICU consultant. This is Claire. We're with the code team. Would you guys be able to give us a handover of what's happened? So
Yeah, I'm Tom, I'm the junior medical officer, I've been leading this code. This is Charlie, who's a 3-month-old 5-kilo child who's in asystolic cardiac arrest. We're on the 2nd cycle of CPR. He's got a background of a few days' history of severe diarrhea and vomiting. Currently we've given him 1 dose of adrenaline and we are in the process of giving our first 20 ml per kilo normal saline fluid bolus. The plan was to continue down the non-shockable side of the algorithm, continue further boluses of adrenaline and further boluses of fluid, to take a venous blood gas to check for electrolyte imbalance, and to continue to check the rest of the 4 H's and the 4 T's.
Okay, so 3-month-old asystolic arrest, likely due to hypovolemia
Yes.
or electrolyte abnormalities, given the history, and you're following the non-shockable algorithm, checking the 4 H's and 4 T's. That sounds great. If it's okay, I'll take over leadership of the code now.
That's fine, thank you, Simon.
Okay. Okay, so we'll continue down the non-shockable rhythm. Tom, do you want to take over CPR?
To summarise, the non-technical skills that are essential during a paediatric resuscitation are: call for help early, allocate roles, perform continuous basic life support, use isobar to hand over, have a clear leader, communicate effectively, know the dose of adrenaline, use a cognitive aid where possible, be a good follower. We do hope that this video will be useful to you, and we're grateful to WA Clinical Training Network for their assistance.